introducing me. Today we will discuss failed ACL reconstruction, and we'll concentrate more on the femoral tunnel problem during reconstruction. So revision ACL reconstruction has a less favorable outcome than primary reconstruction. The patient usually have been documented to be lower by 60% following revision. We'll concentrate more on re-instability after ACL reconstruction, failure to control rotation and anteroposterior stability. What happened during the first surgery and what went wrong? We found at the femoral site that the main reason is non-anatomical position, hardware failure, or tunnel dilatation or reaction. Femoral tunnel in our studies was responsible for error in nearly 50% of cases. And as we all know, that the anatomic site is back to the arcuate and bifurcate ligament ridge. And when you are going anterior or even posterior, you will get failure. Two vertical tunnel or posterior blowout are femoral tunnel problems. So we have revised cases of failed ACL nearly from 1995 to 2020 in a combined prospective and retrospective study on 760 patients with re-instability. We have did this study in our institute, Cairo University, and with our colleague in Asia and some centers of Europe to evaluate the problem. Nearly in early reconstruction during 1995 to 20, we have found that anterior position at the femoral site was the most important. Declining to 2020, we found that the area of anatomic reconstruction has improved, but still it has some superior position. So we concentrate on the entry point at the knee, not the direction of the tunnel. We didn't find any correlation between the inclination of the tunnel and the degree of re-instability. But the most important is the site of entry at the femoral site inside the knee. Hardware failure, we encountered more with interference screw. Re-instability is higher, nearly reaching 25%. Divergence is the most common error, reactions, or the diameter of the screw. All types of fixation can do failure, even with endo button, soft tissue interposition, or failure of the connecting suture material. We have found cases of failure of suture material, and even transverse fixation. We have a little high with rigid fix, 70%, comparative to transfix, 4%. One of the most important is the graft size. Semitendinosus gracilis is slightly higher than bone tendon bone, size less than 8 millimeter, has a 30% failure, while size from 8 to 10 has 15%, size over 10 or more has 8%. The failure at the femoral tunnel is mainly either due to dilatation or blowout. We assess the patient by X-ray, CT, MRI, but we found that CT is the most accurate method for detection and planning for revision. Femoral tunnel evaluation had been done by CT scanning regarding the size, the entry point at the knee, and the dilatation. We use a grid method to determine exact point of entry, and direction grading method or roller method. We can introduce or planning for the next step of revision. Tunnel defect has many types, and we find that at the femoral site, mainly due to reaction or oversized drilling or reaction around the plate or around the interference screw. These are different types of reaction and different types of widening and possible blowout. So during revision at the femoral site, we encountered cases for non-anatomic with no defect. We are happy because we don't interfere with the previous ACL tunnel. We do another tunnel, leaving all implants in place unless it's infected or loose, and we don't interfere with the previous tunnel nor fixation. We do our anatomic tunnel, and we were happy during revising these cases. In anatomic, with no dilatation, we are unhappy because we have to remove or interfere with the previous surgery, because most cases we have to remove interference screw to drill at the same tunnel, and we have to choose another method of fixation. We prefer to do an endo button or suspensory fixation. In anatomic with dilatation, we either go to two-stage reconstruction. We found it better than single stage. We use tibial bone graft, like biological. We take it like press fit, or bone paste. We don't have many bone paste here in Egypt. Allograft is here but limited. Here is our different types of defect. We graft this as a first stage. We have to correct all the tunnel wall, removing all debris from the previous surgery, especially with biodegradable implants. We have to correct very meticulously around the tunnel, and then we put our graft, and then after nearly 6 months, we go for reconstruction. Thank you so much.